Good evening, everybody, and welcome to tonight's alumni webinar series, sponsored by the Alumni Association of FDU and the Office of Alumni Relations. As always, we hope everyone that joined us tonight is doing well and that you and your families are in good health during these challenging times. I do want to take a quick moment to let everybody know that tonight's webinar is being recorded so that we can share with our fellow alumni and friends who couldn't be with us tonight. We have muted all participants upon entry, and we kindly ask that you keep yourself muted and your videos turned off throughout the presentation so that we can focus on our presenters. At the end of tonight's presentation, we will have a Q&A session. Many of the questions were submitted at the time of registration, and thank you for those of you who submitted questions. There's some great questions on there for this evening, but we will also be taking questions via chat. So at any time during the presentation, you can hover your mouse over the bottom of the screen where you'll see a little button that says chat, and you can type your question at any time. Please be sure to include your name and class year so that we can give you a shout out. At this time, I'd like to welcome Dr. Karen Lewis, the Associate Vice President of University Advancement.
Thanks, Jennifer. And it's wonderful to be here this evening with everyone. And I hope everyone's doing well and enjoying the start of your summer. As usual, after tonight's webinar, we encourage everyone to take a minute to complete and submit a brief survey where you can provide feedback for our presenters and also give us any interest that you have for future programs. A special thank you to Dr. McGlinchey, Assistant Professor of the School of Psychology, for her webinar discussing tips for a good night's sleep during the pandemic. If you weren't able to join us last month, you can access that webinar as well as other webinars on the alumni website. This evening's webinar, Caring for Older Adults Amidst the COVID-19 Crisis, Resources, Strategies to Promote Safety and Wellness, will be presented by Dr. Deanna Gray-Micelli along with her colleague, Dr. Alison Kris. As a nationally certified gerontological nurse practitioner, Dr. Gray-Micelli practiced in ambulatory geriatrics and dementia evaluation program and directed a fall assessment and prevention program and managed the care along with an interdisciplinary geriatric team of 120 older nursing home residents for over 14 years. This long-term care expertise has framed her bedside clinical teaching and research initiatives focused on improving the quality of life and safety for vulnerable, frail elders in long-term care. Leveraging her expertise in the care of frail elders in long-term care has resulted in many opportunities to work hand in hand with frontline nursing staff and professional registered nurses at the point of care to provide knowledge translation about important sentinel events affecting the quality of care to older adults in long-term care, where some 1.5 million older adults reside. For over 15 years, Dr. Gray-Micelli has collaborated with interprofessional colleagues from geriatric medicine, health, psychology, biostatistics, and more, recently with Rutgers University's biomedical engineers and health economists to create and test innovative practice-based solutions for practice change in the care of frail elders living in long-term care. Their focus has been to create technological solutions of falls prevention and more recently with climate change to aid the detection of temperature extremes in long-term care environments. Currently, Dr. Gray-Micelli is professor in the Jefferson College of Nursing at Thomas Jefferson University and the Director of Implementation Science for Falls Prevention at the Jefferson Center for Injury Research and Prevention. The healthcare community has recognized Dr. Gray-Micelli's contributions in the field of nursing and best practice approaches for older adults. In 2019, she was recognized as a distinguished educator in gerontological nursing from the National Hartford Centers for Gerontological Nursing Excellence, where she serves as an educational liaison. And finally, Dr. Micelli was awarded the prestigious Pinnacle Award from Fairleigh Dickinson University, her alma mater. Dr. Gray-Micelli, I'm going to let you introduce Dr. Kris now and give you the Zoom camera.
Thank you so much, Dr. Lewis. That was a very nice introduction. I'm really happy to be with everyone tonight, and I'm very fortunate to have my close colleague with us, Dr. Alison Kris, who is an associate professor and the Elizabeth D. Camp McNerney Professor of Health Sciences in the School of Nursing at Fairfield University in Connecticut. She completed her BSN degree at the University of Pennsylvania, and she earned her PhD from the University of California, San Francisco, and was the recipient of a prestigious John A. Hartford Foundation postdoctoral fellowship, where she focused her care on older adults. That's been a strong focus of her career and scholarship. As a geriatric nurse, she remains particularly concerned about the quality of care delivered to older adults in nursing homes. And her program of research systematically addresses the many challenges faced by older adults living in nursing homes and centers on addressing the unmet needs for this vulnerable older adult population. Dr. Kris has been leading efforts to address the COVID-19 crisis in Connecticut nursing homes through her roles, drafting policy recommendations to help address this crisis. I'm really happy that she's joined us tonight as part of our conversation. To start, I'd like to share with you some slides, and just to frame what we'll be talking about tonight, to give you an overview, we'll start with a little background on the demography of the older adult in the country as well as in the state of New Jersey. I'll touch upon living arrangements and support systems, and then we'll move into talking about the health and well-being and the needs of older adults that can be unmet, and who is really at high risk for having issues related to mental health and health failures. We'll also talk about social connections and resources to keep older people healthy and functioning for as long as possible, and then move into some of the national challenges, the public health emergency that we have in front of us, implications for older adults residing in institutional long-term care facilities, some lessons that we've learned along the way, and then opening up for a question and answer period with everyone. So to start, we ask, who are the elderly? And if you look across the country, really we have a number of older people that enter into this category of elderly over the age of 65 from many walks of life. And in numbers, we know that there are currently 56 million older people, and this landscape slide shows the progression from 1900 to a population projection forecasting of 2060, where we can anticipate 98.2 million people being over the chronological age of 65. Currently in 2020, we are standing at about 56.4 million people. And so you can really see this rise in projection. What I want to share with you is that one of the take-home points is among people over age 65 is a separate subset population over the age of 85, which are the fastest growing age group among persons over the age of 65 in the country. And you can see from this graph, and this is a little outdated, but it hasn't really changed in terms of the where the numbers and percentages of older people will be residing is the Midwestern part of the country, and also on the coastal states. So if we turn to New Jersey, we currently have 1.6 million people that chronologically are over the age of 60, and they have populated heavily in Ocean County, 27%, and also Cape May County, 29%. And this is from the census data, which comes out every 10 years. So 2010 is the most current one that the state has produced. And here you can see from 21 counties, again, 1.6 million people over the age of 60, but you can also see the numbers of people that are over the ages of 70 to 85 plus. There's quite a few in this age group. And those are the folks, particularly 85 plus, that we're very concerned about. as healthcare providers. And I'll share with you why that is in a few slides. But the population projections for people 85 in the state of New Jersey are going to be the highest in the counties of Bergen. I know it's hard to see the slide, the color here, but it's Bergen County. You can see Middlesex County is going to peak, and also Ocean County. So where do older people reside? Besides, you know, in those particular counties, wherever their county is where they reside, we know that the majority of people are living independently in their own homes, whether it's you know, an apartment, a condominium, living with other family members. Only up to 5% of older adults in the United States reside in a long-term care facility, and long-term care includes things like a assisted living facility or a skilled nursing facility. Those represent about 5%, and number 1.63 million people. People that enter into this long-term care institutional setting are people who have functional impairment and disability. They're unable to live independently, safely, perhaps, and need assistance, nursing assistance, and in some cases, 24-hour a day assistance. And when you look at the population in the country affected by or that are living in nursing homes, you also see that if you were to drill down, that a large percentage of people in nursing homes have dementia. And dementia is a term that's used to describe an irreversible cognitive decline that is irreversible. And one of the most common forms of dementia is Alzheimer's disease. So I'll spend a little bit of time talking about that. But in general, the caregiving needs increase with age, so that we can see that over the age of 85, people need additional help. And this is the combination of not age per se, but disease, polypharmacy, functional declines, comorbidities are very high. And these things taken together affect function. And when function is affected, then that's when there's deficits in ADL that require additional assistance in terms of meeting the personal needs and the instrumental activities of daily living needs. Also, I will point out, I would be remiss if I didn't say that, you know, there's 1 million grandparents over the age of 60 that are responsible for one or more grandchildren under the age of 18 living with them. And also among the developmental disability community, of the 3.6 million people, 24% of them have caregivers over the age of 60. And this is from the National Center for Health Statistics. The support services that we have leveraged and we have seen higher increased utilization include home delivered meals and home delivered groceries for people who are quarantined in their home or have no other access to family caregiving, living companions, a higher use of telephone calls and frequent visits with their physicians through telehealth, and also staying in touch with, you know, Zooming and Skyping and so forth through those venues. If you look at the health status of older people over 65 in this country, you'll see that 90% or more have one or more chronic conditions. And the chronic conditions that we see increase also in 75 plus and 85 age group continue to go up. They include things like hypertension, seen 58% of the population, hyperlipidemia or hypercholesterolemia is 48%, osteoarthritis 31%, and diabetes 27%. These become chronic illnesses, and these are what typifies a characteristic of an older person, usually having chronicity. Multimorbidity is another term that we use. So in the healthcare system, you're likely to encounter an older adult. If you're in the oncologist's office, 63% of older adults are visiting oncologists, cardiologists, urologists, and you can see here that there are just a high predominant user of the healthcare system. And 90% of people in nursing homes are over the age of 65. The unique issues, irrespective of any disease, as we see older people growing old, is that there is a higher incidence of what we call atypical presentation. And what that means is that our textbook classic, signs and symptoms for diseases do not present the same. They do not appear the same in older adults many times. And as a result of that, it requires really an expert to be able to drill down and figure out what's going on. And I'm mentioning this because some of the questions were related to, anxiety and perhaps confusion. That could be a harbinger of confusion. And we know that confusion, mental confusion, is a symptom that's associated with many other diseases. So that's important to know that this atypical presentation is very commonplace in care of older adults. And you can see here the number of disabilities and functional impairments that increase with age. The main point from this slide is, look at this, over the age of 85, 50% need assistance. And I was looking at some data from Medicare that showed that of the 50% that need assistance in personal care, only 25% are getting that kind of assistance. So that is really very important to recognize in terms of if their needs are being met. Alzheimer's disease is the 6th leading cause of death, of mortality in the country for people over the age of 65. It does increase with age. It currently represents about 5 million people have Alzheimer's disease. And you can see here from this slide that, while we're at 5.6 million right now, look at the trajectory that is going to take place in the next several years. People that we are very concerned about are, yes, older people, 65 plus, that are healthy and well, but there's a subset of the population that we are more concerned about, which are the frail elderly. And the frail elderly have a higher incidence of hospitalizations, mortality, and comorbidities. And for that reason, frailty is a condition that when we seek a frail older adult, our antennas are up and we are, more aggressive with looking at different interventions to help maintain function and prevent functional decline. Frailty is highlighted by unexplained weight loss of 10 pounds or more within a short period of time, weakness, fatigue, low activity level, and slowness. And again, we know that frail older adults are the ones that are more often to be hospitalized and again have a higher mortality rate than non-frail elders. And a little bit of stress right here can cause a lot of illness in these folks. They're at high risk for falling, recurrent falls, immobility, inability to get up and to be mobile, cognitive decline, and also dehydration, malnutrition, and depression. So caring for older adults is both complex and challenging, and for that reason, we need to have an adequately trained workforce. And this is a huge issue that we face in our country. I've been in geriatrics as a provider for 37 years. This is no different than it was 37 years ago. We know there's a shortfall in every state. In the state of New Jersey, there's a 54% shortfall in the number of geriatricians. I looked it up recently, and there's only 18 geriatricians in the state of New Jersey. Some states are blessed with more geriatric providers than we are, and given our population demography, we certainly need a higher number of persons specialized in geriatrics and also geriatric nursing. So what are the best practices for maintaining the health and wellness of older adults? It really falls along these lines of physical health and functioning, maintaining safety, and keeping people at high level of function for as long as possible. So we're allowing them to age in place, which is really the best of both worlds. Attending to their psychological issues in terms of late life transitions. We know that older adults are resilient. Many times they respond to many life changes, including relocation, retirement, death of a spouse, having a serious illness or injury, assumption of caregiver roles, being a grandparent, and they are able to adjust well. However, there is a subsection of older adults who do have mental illness. It's been estimated that about 20% of persons over the age of 65 have some mental illness, which may take the form of a major depression. It may be a schizoaffective disorder, a schizophrenia, or the type of mental health issue. But certainly, we're very attuned to this particularly worsening or the new onset of anxiety that might occur because of the COVID crisis. Social and emotional status is very, very important to include in our daily care plans for older adults, looking at social support network, friends, family. Always maintaining a sense of personal control is really vital, that they have choice, that they're able to exercise their personal choice. And this is why, this COVID crisis has created a lot of issues for us as we care for older people that happen to be institutionalized. Staying connected through engagement and critical to avoid isolation. There are many older people living alone in the state of New Jersey and around this country who are dependent on family caregivers and other support systems to get them through their day. And isolation is something that can occur, and we are, poised to prevent that through different avenues. Other important aspects of mental health and well-being is one's spirituality, which is different than religion, but their spirituality and their connectedness, and having access to trained providers, as I mentioned. There was a wonderful training and education PowerPoint that I wanted to share with you to promote optimal health and mental wellness, which was produced by Laura McNally, and it's available at the NIH, so nih.gov, and she talks about strategies and tools for dealing with stress. And the things that I really liked when I was looking through this was to realize that everyone is affected. It's affecting us all on different levels, and how we manage this and our resilience really depends on a multi-pronged approach. We want to make sure that we attend to the 6 domains of resiliency, which include, maintaining our health and our loved ones' health in terms of nutrition, sleep, and exercise, having a balance, not getting preoccupied. I know there was one time in my life where I could not turn off CNN. I'm glad to say that that time is over, but it's captivating and can lead to, just a constant focus on everything but your health and your wellness. So we want to be very mindful of that. Working out a problem solving and having a resource plan is really important to have that a plan in place. So we have plan A, and then we have plan B and plan C, so that things don't fall between the crack, and that older people are able to stay resilient because they have that support that they need. And it may be very tangible support in terms of frequent phone calls or visits where appropriate, to less type of formal, engagement. But nonetheless, having a plan is very, very important. Also, collaborating with others and realizing that everyone is going through this together and staying positive. She talks about controlling what you can and being aware of there are things that are out of our control. And it's identifying really what are the things on that list that we can do something about, and then working with a goal to meet those needs. So I would urge you to take a look at that. And then the other web site that I really like is called Care Not COVID. It's CARENOT COVID.com. And we're going to have these resources available for you at the end. But this is a way to communicate with loved ones or even older adults that are acquaintances that need a friendly check-in, a friendly visit, and it's through the social network platform where you can send a message to persons in nursing homes and assisted living facilities. And then realizing that, everyone around the globe is affected. And so I myself have relatives in other countries, and, I stumbled upon this website through the GSA, and it's, through the CDC, has a website and a world map, but there's also another resource, and I think it's here, it's this one, which is called ltccovid.org. And so the nice thing about this resource is that you can type in the country and it will give you the latest newspaper articles, you know, headliners, front pagers, and you can read about what is happening in that community, whether it's, you know, in Europe or in Asia, wherever it may be, and to find out what's going on, because there are some misnomers, you know, with the news. So it's nice to stay in that country of origin to find out what exactly is happening. It also has policies and guidance. And then lastly, this resource I really think is a wonderful resource is from WHO, the World Health Organization. And it really talks about the mental health needs that we all have, that we all face. And gives some really great guidance and is very clear about this issue of isolation. And particularly for people with cognitive decline who may not understand, they may become anxious and they may develop anxiety or become stressed, have what we call a catastrophic reaction, and so forth. So providing practical and emotional support through informal networks and families is really important. We talk a lot about that, giving simple facts, posting notes, having reminders, having consistent routine and things like that help during this crisis that we're in. In terms of our local resources in New Jersey, there's a number of them, and you can actually go into the state.nj.us/health and healthcare facilities, and you'll find the documented facilities. There's 550 COVID positive nursing homes, which include assisted living and nursing homes in the state of New Jersey. And they list them by township and municipality and so forth. And they tell you the number of COVID confirmed cases, the number of COVID confirmed staff. And then, you know, it's updated, I think, every couple of days. So you could take a look at that resource. COVID by the numbers tells us the number of folks that are affected globally. In the United States, up to 1.9 million confirmed deaths. In nursing homes is 95,515. And we know that of the 90,000 residents in New Jersey, we have, as I mentioned, 550 of the facilities are COVID positive. This accounts for about 26,000 COVID positive cases. So we are in a public health emergency, and there's no doubt about that. Our most vulnerable population are the frail elders in long-term care. By far, they have the highest degree of disease burden. They have the highest degree of comorbidity. They have the highest degree of functional limitation. They have the highest degree of lack of resources and support staff that are trained in geriatrics. So this is really a very vulnerable population. And so much so that we know that the American Geriatrics Task Force has been working very closely to send policy recommendations nationally to state government and national and federal government so that we can come up with, you know, some solutions here to these problems. And Alison's going to talk a little bit about that. Before I end, I'd like to mention that the Alzheimer's Association, it's alz.org, has a nice family caregiving tip sheet for caregiving at home, and there's a section on caregiving in nursing homes with some really great suggestions about having to stay socially connected and keeping the loved ones healthy at all times. And if you're interested in the AGS position statement, we can certainly send that to you, but it was a written testimony, and I'm going to just end on that and say that we have a few resources as well that you can look for. I would always recommend the County Office on Aging. They're mandated to have a list of geriatric services in the county that you are contacting. And as well, there are academic geriatric programs affiliated with schools of medicine in each state, and also with medical centers that have geriatricians and so forth. So if you're looking for a geriatric specialist, this is where you should look. So I'm going to stop my slides now, and Dr. Kris will pick up.
Great, thank you so much, Deanna. That's a great introduction to what I'm about to jump into. Can everybody see my screen okay? Yes, can I get a thumbs up? Awesome. Okay, so I am going to talk sort of a little bit specifically about issues around COVID response and COVID response in nursing homes. I've been very involved, as Dr. Gray-Micelli had mentioned, in leading some of the policy here in Connecticut and nationally around nursing home responsiveness to COVID. So just to sort of start off, right, there have been as many plagues as wars in history, yet always plagues and wars take people equally by surprise. And I think this is a very appropriate quote for where we are in terms of COVID responsiveness. We really were caught off guard, especially for really the magnitude of the problems that we saw in nursing homes and that we're about to walk into on a national level. So I think initially, here in Connecticut, as well as nationally, we didn't really know what the best strategy was to prevent spread in nursing homes. So we kind of went back to our old playbook, right? Of, okay, well, how do we prevent or stop other kinds of infectious diseases throughout nursing homes, right? And so we treated it almost like an influenza. So we implemented influenza protocols. And one of the big things that happens, and it happens almost every influenza season, is that the biggest way to prevent spread of influenza in nursing homes is to quarantine all homes. So most states at this point have all of their nursing homes under strict quarantine orders, which means essentially that no family members are allowed in and out. And that policy extends to people like chaplains and other special visitors, ombudsmen, hospice in some situations. So there was this moat, right? We're going to build a moat around the nursing home and we're going to prevent COVID from getting into the nursing home. Unfortunately, what happened relatively quickly is that COVID-19 jumped that barrier, and it jumped that barrier fairly easily because with a large number of the nursing home staff that became sick, right? The nursing home staff was still coming and going from the nursing homes. The staff then brought COVID-19 into the nursing homes. Initially, in most places, there was problems with access to testing. Our nursing home residents didn't have access to testing. You might have seen large-scale sort of drive-through testing places popping up, but obviously your nursing home residents can't utilize the drive-through testing, right? So they were dependent on someone, right? And it varies a little bit state to state, county to county, someone, either the state or a local hospital, coming into the facility and testing nursing home residents. It's a cumbersome process. There were problems procuring PPE initially, not enough PPE for nursing home staff. There was lack of transparency. I know for sure in the New Jersey papers, New York papers, Connecticut papers, many reports of family members not knowing what was going on exactly in their nursing home. Was there COVID present or wasn't there COVID present? And that really stems back to this initial problem with PPE. And that led to some problems with, sick staff, right? So now we have COVID-19 in the nursing homes, not enough PPE available, sick staff, and staff calling out. At one point we had, roughly 20% of staff calling out sick in Connecticut nursing homes. That's really hard to manage, even in the best facilities. So created, some really significant early problems. So at the state level, as well as at the federal level, and we're going to see this nationally as well, there were some problems with the early responsiveness, right? There wasn't enough testing of either residents or staff. We didn't have enough PPE for nurses. We didn't have enough knowledge about how to provide really high quality end-of-life care for these residents. Most of them are DNR. They're not going to go to a hospital to get end-of-life care at the end of life. So once COVID enters a facility, you have a large scale mortality event. How are we going to manage that within a nursing home? Many facilities struggled here. And then there were some issues around maintaining safe staffing ratios here in Connecticut for sure. So initially, we have nursing home residents becoming sick. So the way the process had worked, right, is a nursing home notices someone develops symptoms. They try to find a test somewhere. Maybe they call a local hospital to get somebody to come in to do that testing. So they notice the symptoms, they call the hospital. The hospital arrives 2 days later. They do the test. The results arrive 6 days later. And all of this time, right, the disease is spreading throughout the nursing homes. We began to learn fairly early on, really by the end of March or so, that once you have 1 to 2 nursing home residents become ill, and this is data that came out of Maryland, when they went in as the state and tested 100% of all nursing home residents and staff, they found that between 75 to 100% of residents by that point were COVID positive. So by the time people identified that there was a problem in the facility, the problem had already run amok and had spread really significantly throughout the facility. After this initial sort of wave of infection, then comes the wave of mortality, right? So you start with people getting sick, and then there's the delay. The mortality in Connecticut nursing homes, and really I know this is true in New Jersey, New York as well, is really breathtaking. It created a huge emotional toll on the nursing home staff, right? These nursing home staff members had sometimes cared for these residents for 3, 5, 10 years, and to lose huge numbers of these residents they truly cared about, not just one, but so many, so quickly, created a huge emotional toll on these, on the nursing home staff. We had a large death toll here in Connecticut, really more than 50% of COVID positive nursing home residents. We've lost a total of about 15% of the total nursing home population here in the state of Connecticut. That is more than half of the COVID deaths here in Connecticut. And really in my county, in Fairfield County, 90% of COVID deaths were in nursing homes, right? So this is a huge concentration of mortality that's happening in nursing homes. And really, as Dr. Gray-Micelli alluded to, right, she had mentioned, these are people who are frail. They don't just have one comorbidity. They have 2, 3, 5 comorbidities. They're not just on one medication. They're on 2, 3, 5, 12, 15 medications sometimes. So it's an exceptionally vulnerable population in the nursing homes. And that's really what drove the mortality in this setting. So in addition, there were many things that the state, could have done a little bit differently. Nursing homes really needed a lot of state support here in order to get through this. In some states, and it is varies state by state, there was inadequate financial support. It was very clear that these residents were going to create a huge financial loss for the facilities. They are very expensive to take care of, not only because the PPE is more expensive, they require more staff. They needed to pay higher wages to bring staff in to a nursing home that's rife with COVID. And so it really presented some significant financial challenges. The state of Connecticut specifically did step up eventually with increased funding to the nursing homes to address some of that shortfall. And different states around the country are in different places. I'm not sure how many of you are familiar with how nursing homes are funded, but the majority, about 60% of nursing home residents, their funding comes from Medicaid programs that are funded through the state. And so the state really does control how much money a lot of these nursing homes will get in order to care for these COVID residents. So by upping some Medicaid support for the nursing homes, they were able to address some of that shortfall. And I think we're going to begin to see over time who's going to be able to manage some of that shortfall moving forward. In addition, we have a situation where we have some older adults coming from the community, COVID positive. They go into the hospital and they're not able to return home, or they're in a nursing home, they're COVID positive, they go to the hospital. Now, where do they go next? If they go back to a nursing home, they risk infecting large swaths of the nursing home population. Is that a safe thing to do? What's the best way to handle these residents? We thought initially that there might be a COVID only sort of post-acute care setting for these residents to go to. There were long delays in establishing those facilities, and many family members didn't feel comfortable sending their loved ones to those facilities. So that didn't work out as a policy so well. So targeted policy recommendations for all states, and this is sort of moving forward, right? So all states really should be in a place where they're able to test 100% of their nursing home staff and their nursing home residents. Not all states are here yet. And most states, as a matter of fact, haven't gotten to a place where they have tested 100% of nursing home residents or staff. The state of Connecticut implemented this policy recommendation about a month ago. They're sending out state testers to each facility. There are 219 nursing homes in the state of Connecticut. They are moving at a rate of 1 to 2 nursing homes per day. So this is a recommendation that's going to take a long time to carry out in Connecticut nursing homes. And it's going to be very, very difficult to get good data on how affected some of these nursing homes are until it's very, very late. I'm going to move a little bit more quickly through some of these slides. PPE is still a huge issue for many of these nursing homes. Initially, PPE shipments were prioritized to hospitals, and nursing homes were at the end of the list, right? So here I'm saying, wow, the majority of deaths are happening in nursing homes, but the PPE shipments from the state are going to hospitals. And so nursing homes are still very short on PPE. Initially, it was N95 masks. That situation is beginning to improve. We still have shortages of gowns in many facilities. So we haven't quite gotten there in terms of PPE for nursing homes, at least here in the state of Connecticut. I'm not sure where you are with New Jersey. High quality end-of-life care is going to be a major issue for some states moving forward. We have already gotten through our initial wave here in Connecticut, as well as in New Jersey, in terms of the initial wave of mortality. That will begin as other states, right, begin to see their COVID rates peak in the community. They'll see them peak in nursing homes, and they will experience a similar wave of mortality. And the nursing home staff really do need much more training and support about how to manage end-of-life care, specifically for COVID patients, right, who are not able to see their families. And that's a really unique skill set. Staffing, again, is going to be a major issue. And as the wave of mortality begins to hit places like Florida and Texas, where we already know that there are staffing inadequacies, being able to get staff in when there is a large percentage of the staff out sick is going to present some significant challenges to those states. We had some specific recommendations for Connecticut to help get through it. Some states have established these protocols. I know Texas just announced that they have established a statewide strike team to help support nursing homes that are experiencing problems with staffing. post-acute care facilities are going to be incredibly important moving forward, because now, you know, what do we do next, right? So now we've gotten through this initial phase. What do we do next? We know that our residents with dementia are at particular risk, right? They're hard of hearing, they can't use Zoom, they struggle with even routine care. And so they require some really specialized care. They might need certain kinds of amplifiers. We might need to think about how the nursing home staff can relay messages as opposed to relying on technology. There are unique techniques that we can use in order to test these residents, including things like fecal samples for people who are incontinent, who might be resistant to getting a nasal swab. So there are lots of specifics around there. Where are we nationally? Many states do not collect data from nursing homes. So we don't know in some states where we are in terms of mortality. It's going to be very difficult for those states to understand where they are in their mortality curves. Because if you're expecting half of your mortality to come from nursing homes and you don't have that data, it's just going to create a lack of clarity. We're expecting to see huge losses over the next few weeks in Florida, Texas, California. Places in these warmer climates are going to experience, as we did in New Jersey and Connecticut, really significant problems with morgue capacity. Refrigerated morgue capacity is a huge issue in places that are hot, right? And they'll experience some problems with that. So open questions: how often do we need to test? How are we going to handle hospital discharge? When can we end quarantines and allow people to see their families again? And how are we going to manage the financial struggles of these facilities? The nurses now they're burnt out, they're fatigued. Will this lead to a long-term shortage of nurses? We don't know. We know a lot of the nurses have experienced trauma, and they are going to need help to recover, especially those nurses who are working in nursing homes. So to end on good news, all plagues end eventually. We've gotten through the first peak. In the tri-state area, we'll be better prepared to handle a second peak. If that happens, we don't know that will happen, but if it does, hopefully we'll have some better procedures in place, and we'll just have to stay tuned. So with that, I think I'll turn it over to questions for Dr. Gray-Micelli or for myself.
Hi, everybody. Thank you so much, Dr. Gray-Micelli and Dr. Kris, for your presentations. It was certainly an informative and insightful look into elder care and older adults. Let's move on to the Q&A session. So as I mentioned in the beginning, I am going to share with you both some of the questions that were submitted at the time of registration. And we still have a few minutes, so if anybody has any other questions, submit them via chat now. Here we go. So the first question I have comes from Leon Ernest, and he's an alumnus from 1983. How can a caregiver provide emotional support to an elderly that has anxiety from the disconnect from their family and friends, and the uncertainty that I know both of you talked about in your presentations of not being able to see their loved ones during this time?
Dr. Gray-Micelli, you're on mute.
Thank you. Sorry about that. I could start to answer that question. I think that's a really good question, and it's a very common question that comes up. One of the things I would be really concerned about is that, the level of anxiety that the person might be having. If it's a normal baseline level of anxiety for them, those are some questions that would come to my mind as a clinician practitioner. Is this out of the ordinary, a new onset, for instance, of anxiety, or feeling particularly anxious? Because we do know that there are situations, I mentioned that atypical presentation of illness, but there's also neurological involvement from COVID-19. So I would want to know if this was a intense difference in the person, and if it's not, and that could be kind of asked and answered, that this is not a sudden new onset of anxiety, I would feel rest assured in saying that, saying to the person that everyone, we're in this together and we're all going through this, and just venting and speaking, and sometimes just listening is the first line of helpfulness, is to listen to the person that may be anxious. And you don't want to heighten their anxiety by creating false hope, or by minimizing how they feel. Certainly that's kind of a rule of thumb. Pointing that person in the direction of whomever in the past has been a trusted person for them, that they go to, that they feel comfortable with, is a first step. Making sure that that person they get reassurance from. I know there's situations where, if you put me in touch with someone in my family that, we were having a disagreement with, I don't know if that would be calming for me. But certainly, thinking about those roles and relationships, and kind of asking and answering that question, if this is a normal sense of a response from that person. If it seems to be out of the blue and it seems to be increasing on a fairly regular basis, no matter what you put in place in terms of verbal reassurance, phone calls, things like that, then I would make a call to the primary care provider, because we do know that there is a neurological manifestation of COVID, and we wouldn't want to miss that. So that's how I would handle it.
Thank you for your concern. Leon, if you're on here, I hope that helped address some of your question. We have quite a few questions, and I did get one on chat too, so keep submitting your questions via chat. The next question is from, this is a good one. This is from Patricia Lopakinski. She's an alumna, class of 1981. She states and asks, I'm assuming that all elder care facilities, whether nursing homes or rehabs, have infectious disease doctors on staff. How is it possible that the state of New Jersey was not better prepared for taking care of the nursing home population? Any insight on that?
So I can begin to answer some of that. So here in Connecticut, that actually isn't the case. They do not have infectious disease staff necessarily on staff. And it's an area where they needed more support. Infection control is something that nursing homes have traditionally struggled with, even outside of COVID. And COVID itself is extremely infectious, right? We know that just from the general population, that even in the community, if you're living among family members, you have one family member that's infected, there's a very high transmission rate within a family. So you're talking about a population of nursing home residents who live together, eat together, socialize together, and then you have CNAs that go from room to room to room. And so it's really a setup that is rife for transmission in this particular case. In addition, this is, we believe, an airborne disease. Most nursing homes do not have any kind of airborne isolation. It's just not something that traditionally exists in nursing homes. They're not just set up for it. So even if they did have infection control staff mandated, some states do, I'm not sure about New Jersey, it remains a challenge to be able to control the spread. The best way to control the spread, we believe, just from the limited research we have, is to try to cohort residents together that are positive. And the only way to cohort residents together that are positive is to go in, test 100% of the residents and staff, and move residents, which we know is initially very disruptive, especially for residents with dementia, and get them positive patients on a wing with only positive patients, and the negative patients only with negative patients, and keep those two populations as separate as possible. But without testing, it becomes very difficult to adequately cohort residents. And sometimes by the time people get in to do the testing, it's too late.
Yeah, I'd like to add something to what Dr. Kris said. In terms of I just want to make a statement about the consultation issue that you brought up. That it is true that there are a number of consultants on staff. Doesn't mean that they're physically present, however. So you can have a consultant cardiologist that's at mainline cardiology, and they could be covering, 20 nursing homes, but they're not physically present. They're a consultant available by phone and so forth. And I would also, make a statement that the geriatrician shortfall in the state of New Jersey, we have 18 board certified geriatricians to care for 1.6 million people over the age of 60. And so the issue with infectious disease is very similar. There's not that many infectious disease people in the state of New Jersey, of which are dedicating some of their practice to long-term care. And even at that, it would be a consultant. So I hope that makes sense, but I just want to explain, because my dad actually was an infectious disease specialist, and he was in charge in the County of Union for, I think, 2 nursing homes, but there's 280 nursing homes. So where are these other people coming from? And the fact of the matter is that there's a shortfall, and they're not coming from anywhere because they don't exist. So even though it says consult on record, it doesn't mean that the person is physically there. So for this reason, the CDC has recommended this infection control response team. In this, I can speak to the state of New Jersey. They have that going on in the state of New Jersey. There's some discord and some angst going on right now with state officials in terms of their role, but they are present for policy and for making sure that everyone gets tested. So I just wanted to add that.
Thank you both. I think that was certainly informative, because I think a lot of people did assume that these infectious disease doctors were on staff, and I think that helps understand how some of the spread happens so quickly. We probably have time for about 2 more questions. So this question comes from Tony Lee Sangastanio, class of 1998. How to best support a parent or elderly relative who has only a couple months to live, as their medication decreases, and so will their quality of life. So what are some tips you have for family members best supporting their family members?
Do you want to take that, or should I?
Yeah, do you want to take that one? Because
sure, absolutely. Yes. So first, I'll just mention. So if someone is approaching the end of life, it doesn't necessarily mean that we're going to stop their medications, right? We might stop things like a cholesterol medication or a diabetes medication, but that's really a point where we take a look at what an older adult might be taking, right? And selectively reduce the things that we think are no longer necessary, right? So we don't care about cholesterol if you have a few weeks to live, but we care about pain, and we care about shortness of breath. So those might be areas where we would actually add some medications, right? Add some morphine to help with comfort, add some medications to help with anxiety, as Dr. Gray-Micelli mentioned, right? So at the end of life, especially with COVID, there can be some anxiety around shortness of breath. There are medications we can use in order to help treat that. So, and then in terms of quality of life, how do we ensure really good quality of life for these residents? So for people in the community or in the hospital, many facilities will allow family members at the end of life. So that's important to know. Even though in the state of Connecticut, they are under quarantine, they will not allow family members, they will make an exception at the end of life. And family members can press their facilities to try to get in to see their loved ones at the end of life. It's a very important part of closure, is being able to have that in-person access to your loved one. And so I would recommend that family members press for that. For people in the community, Hospice organizations do an excellent job of providing high quality end-of-life care. So if it's an anticipated death, and you know that someone only has a short time to live, hospice is a great option for those people. It's covered under Medicare. It's a standard benefit. So often there's no or limited cost to families. So that can be a great point of referral. Communicate with their providers, right? It's important if the provider hasn't had the conversation about what end of life is going to look like for your loved one, then family members need to initiate that conversation.
Yeah. The other thing I would add is that, where the person is residing. So that's really important because of the closeness, as Dr. Kris was saying, that emotional bond and connection and being there. And if the person, there's something on the Alzheimer's website about transferring out of the nursing home to someone's home. And so that's what came to mind for me, was that if the person is COVID negative, it would be easy to make that transition if those resources were in place where they could die at home. And I always think about that old adage that nobody really wants to die in a hospital or in a nursing home if they have the choice. And in this situation where it's a grave situation and, they perhaps could be not in quarantine, or they have already passed through that hurdle, that would be something to consider, to think about that, moving them into the home if it was possible. I just want to add that.
Thank you both. And it's great. Every question gets 2 responses and more information. So here's our final question, and this one came in via chat from Lori Reynolds, and I thought that this was a great wrap up to everything that we talked about tonight. Do you anticipate an overall shift in the use of nursing homes, perhaps because of COVID, perhaps more home caregivers or redesigns of homes themselves, maybe things, isolation rooms, ventilation systems? What are some of the shifts that we're going to see as a result of the pandemic?
So I would absolutely anticipate a shift in use of nursing homes, at least in the short term. Someone coming out of skilled rehab, of maybe they have a post-hip replacement, right? Oftentimes those people will go for short-term placement in a nursing home. Family members right now are opting not to do that. They're opting to go home and have physical therapy instead, come in and out of their home, rather than going into a skilled rehab where they're going to have those facilities on site. So you already see family members making those changes in decision making, especially for post-acute care. I see in the question, more pay for home caregivers. I don't know. I guess we'll see. It has always traditionally been a fairly low wage work, but it's possible that if there's a shortage of workers, pay will go up. Redesign of the homes themselves. That is tricky. So remember, most nursing homes are paid on a per person rate, right? So we have your one person, we charge you one rate. Do they want to take some of their money and invest it in a ventilation system? Do they want to take some of that money and invest it in having single rooms instead of double rooms, right? That's going to mean they're going to half their revenue if they have half the patients. And so it would be a big revenue hit for some of these nursing homes to rework the architecture to be able to manage COVID. So they would either need sort of a carrot or a stick in order to move in that direction. They would either need a carrot in terms of increased state funding in order to be able to do that, or a stick in terms of, hey, you're going to be fined if your facility cannot provide a safe environment for these residents. And so it may be both, but certainly a for-profit nursing home is not going to want to take a profit hit in order to engage in facility redesign unless they're going to see a revenue, a source of revenue in the future, especially now that we're thinking that there's going to be less demand for nursing home care in the future.
Yeah, I'd like to add to Dr. Kris's comment. I think too that this is a huge wake-up call for nursing home industry and also for the CMS, for the government. And I think that, there are going to be ways that will be created from this tragedy where CMS can reimburse nursing homes at a higher rate, provided that they have additional services like a ventilator unit. Or we know in the state of New Jersey, for instance, there's 4 or 5 ventilator units, and they're paid at a higher rate. But this opens the door for the opportunity to have really more specialized care for this subpopulation that's very at high risk and really the drivers of mortality and hospitalization. So I think that CMS may have a call for it to incentivize facilities. And then the other thing I would just say is that I would be surprised if there weren't opportunities, to do capital improvement things for the facilities to get involved and have access to federal money if they do a capital improvement project, like add a wing that could house, 30 or 40 beds that had a specialty focus. So I kind of think that may, there's going to be some incentives here that develop on the federal and the state level to meet the needs of our society. And these elderly folks are our society. They're you and I in 40 or 50 years from now. They are all of us, and we cannot have things a status quo in the way it's been, because it's just not working. Look at the high rate of mortality with our frail elderly folks. If we had things in place up until this point, this may not have happened. And so I think that it's a wake-up call for everyone, for the state, for the feds, for CMS that reimburses the facilities, for private facilities to look into their capital improvement campaign, opportunities for medical schools to realign with nursing homes. That was back 30 years ago, the Teaching Nursing Home projects. That opportunity, I think, is going to be it's going to play out. I hope it does. I really hope it does in my lifetime.
Well, thank you both. And I think, Deanna, you left us with some something to really think about and stew on, is that this is going to be us in 30 or 40 years, and for some people even less. So hopefully we see some of the positive change come out of some of the challenging situations that we've been facing recently. I wanted to thank you both. Thank you so much, Dr. Gray-Micelli and Dr. Kris, for your presentations tonight. And I really hope that everybody was able to have some takeaway this evening from what they were able to share with us. I wanted to thank everybody in our alumni and friends community for joining our webinar tonight. Please keep an eye out. We will be sending an email shortly after we conclude this evening with an evaluation of tonight's webinar. And we always love to get feedback on the webinar, as well as some input on what some future topics you would like to see. So please make sure to keep an eye out for that email. Thank you, everybody, for joining us. Thank you again, Drs. Gray-Micelli and Kris. And everybody have a good evening. Stay safe and stay well. Thank you very much.
Thank you.